Coagulation, laboratory evaluation of hemostasis. The tests used to measure secondary hemostasis. For specimen collection, sodium citrate, either 3.8 or 3.2%, is used. 3.2% is recommended for platelet aggregation. Whole blood to anticoagulant ratio 9:1. You must fill the tubes to within 90% capacity because a short draw affects results. Use the plastic tubes or siliconized glassware. Glass activates factor 12 and platelets will adhere to glass. Testing interference. Hemolyzed samples should not be used for platelet aggregation. The platelets contain ADP, which is used in platelet aggregation tests. Lipemic samples may cause problems in optical coagulation analyzers. Effect of increased red blood cells on testing. Patients with polycythemia or increased red blood cells will have prolonged coagulation test results due to a change in the ratio of anticoagulant to plasma. Hematocrits greater than 55%, as in polycythemia, have decreased plasma, thus increasing the proportion of anticoagulant in the blood. The citrate that is left unbound to the calcium in the sample due to excess will bind the calcium chloride reagent used in the test, causing an increased clotting time. The amount of citrate should be adjusted or decreased before specimen collection to compensate for the elevated hematocrit. Effect of storage on results. Coagulation test results may be shortened when plasma is stored for longer than 4 hours at 4 degrees Celsius because of the cold activation of factor 7. Prothrombin time. Measures the extrinsic and common pathway. Initiated by tissue thromboplastin. Measures factors 7, 10, 5, 2, and 1. Factor 13, or fibrin stabilizing factor, is not measured. This test ends when fibrin is first formed, before factor 13 has a chance to stabilize the clot. PT is used to measure Coumadin, warfarin, and dicumarol anticoagulant therapy. It's an oral anticoagulant. INR is used to standardize the test. Reagents. Calcium chloride, or CaCl2. Calcium is needed for clotting. Blood is collected in sodium citrate, which binds or chelates calcium. Therefore, calcium is added to replace the bound calcium. Tissue thromboplastin reagent, which is made from rabbit brain, lung, placental, brain-lung combination, or produced by recombinant technology, contains platelet phospholipid. Reagents and plasma are pre-warmed to 37 degrees prior to testing. Significance of clotting time results. Increased clotting time or abnormal results occur in deficiencies of factor 7, 10, 5, 2, 1, or anticoagulant therapy. Significance of PT results. PT is used to monitor coumarin, an oral anticoagulant therapy. Coumarin works by decreasing the vitamin K-dependent factors, or inhibiting the formation of the normal level of vitamin K-dependent factors. Vitamin K-dependent factors are 2, 7, 9, and 10. Factor 7 is the first factor to become lower, therefore PT is used to monitor therapy because it measures factor 7. International Normalized Ratio, or INR. The strength of the thromboplastin reagent can vary and causes PT clotting time results to vary. Therefore, it is hard to monitor Coumadin therapy if the patient has PT performed at different labs. The INR was developed for the purpose of standardizing the monitoring of coumarin therapy by standardizing results of the prothrombin time. The lack of uniformity for reporting of PTs, along with variations in thromboplastin sensitivities, instrumentation, and methodologies, have led to interlaboratory variation in patients' PT results. Use of the INR value eliminates problems associated with comparing PT results and allows physicians to accurately monitor oral anticoagulant therapy on a worldwide basis. This makes the INR results of the PT comparable from lab to lab. The calculation for INR is the patient's PT over the mean of normal population PT times the ISI. The mean of the normal population PT is determined by the lab. The ISI is the International Sensitivity Index from the manufacturer. The mean of the normal population, or the PT reference interval, is a value that varies from site to site depending on the patient population, type of thromboplastin used, type of instrument used, and pH and purity of the reagent diluent. Each lab must establish its own range with each new lot of reagents, or at least once a year. The mean value is determined by the lab by testing a sample of at least 20 specimens from healthy donors of both sexes spanning the adult age range. They must perform this testing over several days. The ISI is the number that represents the sensitivity of the thromboplastin reagent, a value used to represent the responsiveness of thromboplastin reagent toward sample plasmas from patients on Coumadin. The ISI number is provided by the company from whom the thromboplastin reagent is purchased. The manufacturer of the thromboplastin furnishes the INR value that corresponds to the lot or batch of thromboplastin sent to the lab. The ISI is based on the comparison of sensitivity of the lab's thromboplastin to the World Health Organization reference thromboplastin. Thromboplastins with a low ISI, or close to 1, is considered to be very sensitive. The lower the ISI, the more responsive the agent. It will cause plasma deficient and clotting factors to have a longer PT, thus identifying abnormalities more readily. PT ranges. PT reference range is under 13 seconds. The therapeutic goal is an INR between 2 and 3.5. PT is used to measure the extrinsic and common pathway of the clotting cascade. The factors measured are 7, 10, 5, 2, and 1. A prolonged PT would be caused by deficiencies in factors 7, 10, 5, 2, or 1, or in anticoagulant therapy. The reagents used during the PT test are calcium chloride and tissue thromboplastin reagent. INR stands for International Normalized Ratio, and ISI stands for International Sensitivity Index. The formula for calculating the INR is the patient PT over the mean of normal population PT times the ISI. The reference range for the PT is under 13 seconds, with the therapeutic goal being between 2 and 3.5. The PT INR is used to monitor the anticoagulant Coumadin, warfarin, or dicumarol. Coumadin works by decreasing the vitamin K-dependent factors, which inhibits the formation of the normal level of vitamin K-dependent factors. Activated partial thromboplastin time measures the intrinsic and common clotting pathway. It measures factors 12, 11, 9, 8, 10, 5, 2, and 1. It also measures prekallikrein and high molecular weight kininogen. It does not measure factors 7 or 13. APT test reagents are calcium chloride and an activator. The activators typically used are glass, ellagic acid, kaolin, silica, and cellite. These activators increase the contact reaction. Phospholipids are substituted for platelets. They can get them from rabbit brain, cephalin or dehydrated rabbit brain, bovine brain, and soybean. The reference range for the APTT is 20 to 40 seconds. The therapeutic goal, if on heparin, is 1.5 to 2.5 times the normal. Example of normal is 30 seconds. A patient on APTT should be 45 to 100 seconds. Abnormal results, or prolonged clotting times, are seen in deficiencies of factor 12, 11, 9, 8, 10, 5, 2, and 1. Any clotting factor except factors 7 and 13. Results are abnormal if a factor deficiency is 30% or less. Abnormal results can also be seen in the presence of a circulating anticoagulant or acquired inhibitor. APTT is used to monitor heparin therapy. It has abnormal or prolonged results with anticoagulant therapy. APTT is useful in monitoring high-level heparin therapy. It has variable effectiveness in monitoring low-dose heparin therapy and low molecular weight forms of heparin. Activated clotting time, or whole blood clotting time. Used to monitor heparin therapy. 2 milliliters of blood is added to a tube with diatomaceous earth, which is a particulate clot activator. The tube is thoroughly mixed. The tube is tilted and observed until a clot forms. A normal ACT is 98 seconds. It measures the intrinsic system, or clotting initiated by contact. Thrombin clotting time, or TCT, also known as thrombin time, or TT, measures the time required for thrombin to convert fibrinogen to fibrin. The reagent is thrombin. Thrombin time is prolonged in hypofibrinogenemia, less than 100 milligrams per dl, and dysfibrinogenemia, or abnormal fibrinogen. The treatment is with heparin, not low molecular weight heparin, and circulating fibrin degradation split products. Pathologic circulating inhibitors, or circulating anticoagulants. Repulase time. Identical to thrombin time, except reptilase reagent is used instead of thrombin. Reptilase is a thrombin-like enzyme from snake venom, the venom of Bothrops atrox. Reptilase activates the conversion of fibrinogen to fibrin. Prolonged reptilase time indicates decreased functional fibrinogen. Reptilase reagent is insensitive to the effects of heparin. Good to use with patients on heparin. Russell's viper venom, or Stepvan time. Viper venom activates factor 10. Factor 7 deficiencies will have normal results. Prolonged in deficiency of factor 10, 5, 2, and 1. Diluted Russell's viper venom test is used to detect the lupus anticoagulant. Fibrinogen assay. Modification of the thrombin time. Uses higher concentration, or 25 times that of thrombin, which uses 50 units per milliliter. Patient plasma is diluted 1 to 10. Used to determine the amount of fibrinogen present in the specimen. Anti-factor 10 assay. Test used to monitor low molecular weight heparin therapy. APT test is insensitive to low molecular weight heparin. Clot retraction. Evaluates platelet function, fibrinogen, and fibrinolytic activity. The procedure is to collect the specimen, allow the specimen to clot, check clot for ability to remain intact. The platelet counts are under 100,000 will have abnormal platelet times. Factor assays. Perform a PT and APTT test with specific factor deficient plasma. Example, if patient has decrease in factor 8, test with plasma deficient in factor 8. Can determine the percent of factor present. Clotting factors should be within a range of 40 to 150% to have normal clotting tests. 5 molecular urea solubility, factor 13 screening test. Measures factor 13 activity. Factor 13 stabilized clot remains intact for at least 24 hours in 5 molar urea. Unstabilized clot does not remain intact. It will dissolve in 5 molar urea if bonds provided by factor 13 are not present. Remember, factor 13 is not measured by PTT, APTT, etc. Instrumentation. Mechanical. 2 metal conductors immersed in the sample or plasma. Clot formation causes a change in electrical conductivity between two metal electrodes. Instrumentation. Optical. Light passes through plasma specimen and hits a photodetector. As the clot starts to form, the plasma becomes more opaque. Less light hits the photodetector. Lipemia can affect the test results. Interpret test results. Assuming an inherited or single-factor deficiency, give the factor that is deficient based on the following test results. PT abnormal or increased, APT normal, or PT normal, APTT increased. PTT increased, APTT increased. PT increased, APT increased, thrombin time normal, PT increased, APT increased, TT increased. APTT measures the intrinsic and common clotting pathways. APTT measures factor 12, 11, 9, 8, 10, 5, 2, and 1. It does not measure factors 7 and 13. APTT test reagents are calcium chloride and an activator. Some activators used are glass, ellagic acid, kaolin, silica, and cellite. Phospholipids are also sometimes used. The reference range for APTT is 20 to 40 seconds, and the therapeutic range is 1.5 to 2.5 times normal. APTT is useful for monitoring high-level heparin therapy, but has variable effectiveness in low-dose heparin therapy. Activated clotting time is also used to monitor heparin therapy. A patient on heparin will have an abnormal or prolonged APTT test. Reptilase measures the time it takes to break down fibrinogen to fibrin using reptilase instead of thrombin. In a patient that is on heparin therapy, thrombin time would be increased, but reptilase time would not, because reptilase is not affected by heparin. In the thrombin time test, thrombin is the reagent. Russell's viper venom measures factors 10, 5, 2, and 1. It is used to detect lupus anticoagulant when it's diluted. Factor 13 is measured by 5 molar urea solubility. Sodium citrate is the anticoagulant used for coag tests. The ratio used is 9 to 1. Polycythemia is hematocrit over 55. Adjust the amount of coagulant. Extra anticoagulant will neutralize calcium chloride reagent and increase clotting time. Briefly pre-warm plasma because factor 5 and 8 are labile. PT measures extrinsic and common pathway. The reagents are tissue thromboplastin and calcium dichloride. It monitors Coumadin therapy. There's a formula to calculate INR. INR is used to standardize prothrombin time test results. ISI is the International Sensitivity Index. The reference range for prothrombin time is under 13 seconds, with the therapeutic INR of 2 to 3.5. APTT measures the intrinsic and common pathways. The reagents used are phospholipids, calcium dichlorides, and an activator. It monitors heparin therapy, but not low molecular weight heparin. The reference range for APTT is 20 to 40 seconds, the therapeutic range being 1.5 to 2.5 times normal. Activated clotting time also measures heparin. Thrombin time measures fibrinogen, increased clotting time with heparin. The reagent is thrombin. Reptilase measures fibrinogen, is not affected by heparin, and snake venom is the reagent. Anti-factor 10 assay, used to monitor low molecular weight heparin. Russell's viper venom, or step ven time. Venom activates factor 10 and measures the common pathway. 5 molar urea solubility. It measures factor 13.